Welcome to Care Decoded, the show where we simplify the complex world of risk adjustment, documentation, and AI to power better care. I'm your host, Sunil Nihalani, and today I'm joined by Subbu Ramalingam, who is a former health plan executive and an expert at the intersection of star ratings, risk adjustment, and healthcare quality. So, Subbu, welcome to Care Decoded.
Yeah, thank you, Dr. Sunil.
Sure. You and I have both lived in the trenches of risk adjustment and documentation. You've often said that star ratings aren't just about metrics, they are more about meaning. So, can you just explain what that shift in mindset looks like for a healthcare leader?
Yeah, absolutely. First of all, from a star rating perspective, it's really a quality program, right? And I also see a risk adjustment apart from documentation, and we'll talk about it a lot, during our conversation, is really delivering the right care to people, having the right documentation so that the care delivery system between the providers and payers can coordinate the right care for people based on their conditions. That's really the essence of it in a way. Obviously, there are complexities, within these programs. To answer your question, quality program is about not only bringing the right kind of clinical quality, it's also the right kind of experience that you can actually bring to a member or a patient or an entire population. And it's also intertwined with health equity. It's also intertwined with data, right?
Mhm.
Data, remains the foundation of all. So, from a STARS perspective for Medicare Advantage and also quality from an overall managed care perspective, outside of the metrics we too often focus on, it's also what is the right kind of care that you deliver? What is the meaningful care that you can deliver? What is the meaningful medications that are supposed to be taken by members, etc.? So that's the meaning gets lost many times, in the mix of all the different metrics. So it goes hand in hand. I think people get it conceptually, but it's always we need to get reminded of why it is there and why the dollars matter, why the metrics matter, why the health of the member really matters.
You mentioned it's also about the patient experience. So, can you elaborate on that a little bit? How a patient would experience this whole engagement with the star ratings process?
Yeah. The members really don't care about star ratings in a way, right? Except when they're purchasing a plan. They
Mhm.
want to have a higher quality plan. I mean, the members care about the benefits. The When they pick, call a health plan or interact with the health plan in different means, they want to get the answers that they need, right away. They want to care that they need right away. They want the referral process to be easy. They want the prior auth process to be seamless, and they want less cost, right? They
Yeah.
want the prescriptions whenever they want, wherever they want. So that's the whole experience
Mhm.
component of care in a way. As you know, from a as a practicing physician, quality and the experience that you provide, the doctor provides at the doctor's office, whether it's bedside manners or whether it's actually like the way the clinicians and the caretakers speak to the members or the patient matters. And
Yes.
similar to that, even on the phone call side, even before the members are really engaged with the health plan, whether it's brokers, online, you name it, in all the different channels. The touch points matter, which is very personal. And then after they enroll into a plan, the onboarding experience matters, the ease of which they can connect matters. So, and throughout the time they are on the plan, it's so personal. It's not only the member, but it's also like the caretakers who are actually part of the whole, ecosystem, to take care of the member's health. So that's the ideal experience we want.
Yeah.
However, we have as an industry, we're still evolving. The ideal experience is, what we are all striving for as an ecosystem. So within the star ratings, customer experience is a huge component of the metrics, right? Rightfully so. I mean, having said that, there are a lot of changes in the star rating system, but rightfully so. The response of the members, the feedback of the members matter, whether it's going to be in the star rating system or not. Overall, it's just good business.
Right, right. Well, and also, I think this probably needs to be emphasized more. And I'm talking about me from a clinician's perspective, is emphasizing to the patient that this is all for you at the end of
Yeah,
the day, right? Why is
yeah,
CMS doing all this? It is doing it for your care, so you get better care, right? It's not just about checking boxes and
yeah,
numbers and things like that. Ultimately, it's for the patient's health. And I don't think they always understand that. And at least that's the feedback I've received sometimes, that people are bothering them. And it's not, it's really for their own good,
yeah,
right? At the end of the
yeah,
day.
absolutely.
Yeah.
Yeah, I
No.
mean, to exactly to your point, like as an ecosystem,
Mhm.
we really can do better with that, right? It's the way we engage with them, the way we message with them. The members don't care whether they've got 20 calls
Mhm.
to get, the whatever the benefits the members have. Let's say a health plan has a transportation benefit. If the health plan is reaching out to the member 20 times, 10 times, five
Mhm.
times, whatever, for the transportation benefit, the
Mhm.
member is not thinking about, oh, I want transportation benefit. The member is thinking about, I want to get to the doctor,
Right. Exactly.
right? So
Exactly.
it's like leading with that answer. So I'm just taking that as an example. And we all go through that in our families, right? Even ourselves, consumer of
Exactly. What
healthcare.
problem is it solving?
Yeah, exactly. What is the problem that's solving for me? Yeah, so I think while stars, is not perfect system. I think we all, and as we're talking about this, we all strive for better experience, and if it's incentivized in some way or form to give that better experience, as part of our accountability, whether it's a provider, whether it's a health plan or related to those ecosystems, it's great.
All right. So let's talk a little bit about bridging risk and quality. They are separate programs, but they're very much interrelated, right? So, but most people still think of them as two separate teams, right? At least at the plan level, maybe even at the provider level, that risk adjustment captures payment and quality improvement improves outcomes. So, why is that a false divide, do you think?
Yeah, absolutely. I'll start with a quick analogy, right? So that we all can relate to, some of the
Mhm.
things. Let's say we have a patient or a member who is diabetic, let's say the person was diabetic number of years ago. And then let's say the person is not diabetic anymore. This is an awesome scenario. It's a chronic condition. Typically diabetes stays. Let's
Mhm.
say, the person is not diabetic anymore, going back
Mhm.
in that range. Let's say historically the person has been coded for diabetes with complications, etc.
Mhm.
Right? And the if somebody is diabetic, a population is diabetic, they are also from a quality perspective, it's good to have regular HbA1c checked and eye exams checked, on a regular basis. Those are good care,
Of
right?
course.
So
Yeah.
those are good care, good follow ups, and then the A1C needs to be controlled. You name it, right? So that actually, those are star measures. Eye exam, A1C. There could be kidney health, number of different measures that comes from diabetes. Taking this as an example, but it all starts with eligibility, right? So if
Mhm.
the member, let's say, is not diabetic and is not falling into the appropriate denominator, we call it in stars, right? Our heaters. If it's not falling, they're not falling under the criteria. Let's say the member is overcoded or undercoded, any of those scenarios. Risk adjustment plays a key part in this from a documentation perspective. Obviously, risk adjustment, if it's all about accurate, conditions the members have, so that you or the health plan on related systems can deliver the right care to them in terms of the money that they would need to kind of deliver that care and coordinate care for them. That's the whole point of risk adjustment, right? And then you see there's a mechanism of making sure like you are comparing apples to oranges, from an adjustment perspective. So going back to that example, if it all starts with the right eligibility and coding, and that's an intersection point. There could be a number of intersections, but that's an intersection point where the risk adjustment teams, whether it's in the payer side or an ACO or a provider side, and the quality teams who are really going after the members, engaging them, and connecting them with the right resources or providers to close that gap, um, would need to be really working together, there. So that's an intersection point that I do think in the industry, there everybody gets it. Many people get it. The devil's in the details. The From a structure standpoint, some health plans have it all together. Some health plans have it separate, and then they have a work group where they work, together. Some health plans are still evolving to see how they can actually connect these two concepts. And then there's also cost. Cost is a key part of it, as well. So it all needs to be looked at this, with the lens of population health management, right? You got the quality and stars component, you have the risk adjustment component, the cost component, and the health equity component all, combined together. But having said that, these are complex concepts. There are technical rules for each one of them,
Yeah.
right? So from an evolution perspective, as from a talent perspective and skill perspective, I think there's still more learning to do. People need to, whether it's a leader or teams, they would need to understand a lot of these technical aspects of each of these programs so that they can actually work together in a way that actually feels cohesive, for the member or the patient.
Yeah, and I think speaking of the complexity, I mean, I've seen those HEDIS technical requirements, and they're pretty very, very complex. So perhaps something could be done to simplify it
Yes.
a little bit from that perspective.
Yes, yes, exactly. I mean, while there is, I mean, the HEDIS specifications from NCQA complex. I mean, healthcare is complex, and but at the same time, there is a whole agenda to kind of simplify quality measures. To sometimes less is more,
Mhm.
right? From
Yeah.
X number of hundreds of measures into small set of meaningful measures. There's been a lot of work going on from different companies, and CMS has actually put out a quality agenda out there, a strategy that they put out over a year ago, and then the new administration is also looking through it. So I'm an optimist. In the environment that could be also chaotic, there are opportunities there to kind of streamline some of these for the future.
All right. So next question. So let's get tactical. So how can risk adjustment data actually inform quality improvement work? And can you give us a real world example of this?
Yeah, I think I sort of talked about it in the previous example a little bit, right? So in terms of a member who's diabetic, but at the same time, if we talk about another example here, if members would need a face-to-face visit with the provider, it, and from a quality and star rating perspective, you can actually reach out to members, get the members into care as a practicing physician yourself, Dr. Sunil. Many
Mhm.
times, you would go through like the checklist of like what other members have, what are the preventative screenings that they have, etc. Every time, sometimes things get missed, and you're nudging the member and coordinating the care, for the member, or if there's a member who's actually takes care of herself or himself, like they reach out, and the health plan is also coordinating many times, reaching out to these members. It all starts with the visit,
Right.
right? Apart from the things that the members can do, it all starts with an actual visit, whether it's an annual wellness visit or a normal provider visit. And From a risk adjustment perspective, the conditions that needs to be captured to ensure the health plan knows and the provider knows, what conditions the members have, it needs to be documented during that visit,
Yeah.
right? And that's why, that those are the things that counts as risk adjustment, right? So even just plain and simple example of making sure the members go see the provider, different types of providers, but that that's where it starts,
Right.
right? And whether health plans or providers are trying to coordinate through their member engagement channels, patient engagement channels, or patients or members are incentivized to do certain visits. It all starts there.
Right, right. And to your point that the patient comes in, say, and you do the risk adjustment documentation, but then that drives who is eligible for what quality measure, right?
Yeah,
So say
exactly.
somebody has an aneurysm, then they need a screening for the aneurysm. And I understand that may not be a star measures, but to that point,
Yeah,
that the diagnosis drives what all gets done for the patient, which includes
correct.
quality
Yes,
measures, right?
yes.
Yeah, yeah. Good. All right. So, shifting gears a little bit. So, there's a big shift going on from the retrospective analytics to prospective analytics, prospective documentation, right? And then also, somewhat related, there's also a big shakeup going on in CMS related to what they announced recently that they're hiring like 3,000 coders to do more risk adjustment data validation audits. So, yeah, if you can just talk about these two kind of hot topics, retrospective, prospective, and then the RADV audits.
Yeah, I'll start with RADV audits, right? Hot topic in the industry. Just for context, so I am a managing director for a consulting group. I lead their stars on risk adjustment practice. We are one of the nation's largest HHS RADV auditors, and we've been doing this since inception. Apart from that, we also have number of solutions, for health plans, and being a person who actually worked in risk adjustment quality since 2010. I've gone through RADV audit myself, so the risk adjustment data validation audits. CMS released a press release, Dr. Oz and company a few weeks ago, but last week they specifically sent a memo, about the audit to health plan community. First of all, they are opening up the risk adjustment data validation audits that have been backed up, and they're actually going until 2023 dates of service. So whatever they couldn't do, they're catching up for a few years until 2023 dates of service, which is consider this as like all these submissions that were already done by health plans, and that they got the payments, payments all reconciled, etc. And CMS is going to do a RADB audit on them, right?
Mhm.
So more details, are coming, but the preliminary action CMS has recommended, that CMS has mandated, is basically to ask health plans to send any deletes, if there are any, to send to CMS within the next few weeks. So it's really a really quick, fast timeline to send any deletes that health plans have, and then right after that, they're going to create samples to do RADB audits. So we are not sure whether that it'll be like all of the plans will be audited, which is likely. I mean, if CMS is able to kind of recruit coders, and that's the first step. And then the next step would be, you talked about prospective and retrospective, right? So 2024 and 2025, meaning care that was delivered last year, care that's being delivered right now. For care that's delivered last year for Medicare Advantage, health plans still have time until end of January to submit all the data to CMS so that they can get their payment reconciled if there are any missed payments or additional payments. So all of the health plans are working on this right now, right? They're doing, that's the retrospective work that many of the health plans are doing. In terms of prospective work, health plans are currently doing would be getting members into care, like we talked about earlier, to ensure they're getting into care, they're getting the quality of care, and then the follow-ups needed, and then all the documentation are accurately documented. So, given in the context of RADV audits, health plans would need to amplify their delete process. What does that mean? Delete process means if they find any incorrect diagnosis that they have sent to CMS, they would need to delete them within the time period. So this is a typical thing that health plans should be doing, but at the same time, this is an opportunity to even amplify and make sure like they're mitigating RADV risks and making sure the risk scores and payments are accurate. So, as part of the prospective work that health plans currently do, there is a lot of opportunity for health plans right now to integrate with EMRs, deliver these gaps in care, not only diagnoses that are missed, but also diagnoses that are incorrect, deliver to, tell them to the provider, saying, by the way, is this person diabetic? Is this person having cancer? Is this person having ulcers? All these stuff. The data needs to go to the provider to kind of really make sure that the members still have them, right? So it's an opportunity for the health plan and providers to be even more proactive to mitigate any RADB risk in the future.
Yeah. So I think a big part of that is that the communication needs to happen, right?
Yeah.
That the plans need to be able to communicate to the providers. And that is also not so straightforward, right? So there needs to be, and we are obviously at Inferscience doing work on that, connecting the providers and payers, and so are others. But I still think this is definitely not something we could call entirely a solved problem, right? Because of technical challenges and other challenges. So I think that will have to be getting better and better over time.
Yeah,
Yeah.
absolutely. Yeah, I think that in the next, I see this as a big shift in the industry because like there's billions of dollars in stake, millions in each of these health plans, and then outside that, it is ultimately the care to the member.
Right.
Right. So I think we'll see what happens in the next few weeks. But at the same time, the recommendation is just being proactive and thinking about solutions that actually can better communicate and get providers' life easy. As well, providers are burdened, as you know, Dr. Sunil, from a primary as a primary care. You can speak to that a little bit more, and that's anything that we can make it easy for both the providers and health plan, and eventually, there'll be a lot of saved money in the system.
Yeah, I think actually it's even more than save money in the sense that it's also for some clients at least an existential question, isn't it?
Yeah.
If they get billions and billions clawed back, can they stay in business even?
Yeah, absolutely. Absolutely.
Yeah,
Absolutely.
yeah.
Then there are going to be lawsuits. Also, I mean, I think
Oh yeah.
there was a recent, I just very one health plan, was part of the OIG audit, and I mean they've not accepted it. They're actually going to a lawsuit. So there could be some lawsuits coming, and but at the same time, after these deletes are submitted to CMS, we have to wait and see what happens, but at the same time it's time to get proactive, creative, and also have the right experts by your side, right technology by your side to kind of ease the burden for providers and also the health plan.
Right. Yep. So yeah, while let's see. Let's talk a little bit about connecting coding to human outcomes, which we already did a little bit, but just to elaborate on that. So you said previously that every code tells a story. So can you unpack that idea and what is lost when we treat coding as something clerical as opposed to actually clinical with direct patient impact?
Yeah, absolutely. So, I think we took diabetes as an example previously. We, used that example too often, but at the same time, think about some of these code, some of the conditions that are related to cancer, right? Conceptually, right, cancer treatment is higher cost and relatively more chronic in a way. And, many cancers, obviously got oncology and, primary care, all, really all working together to, take care of the member. It's a lot of cost, for the health plans, obviously a huge burden for the patient and the patient's family itself. It's a tough condition if take different types of cancer, right? And then it also is, if there is a missed cancer diagnosis for the member, talking about the misdiagnosis, it actually, and if it actually goes across, different members, that's a lot of lost revenue for plans who don't know whether these members have cancer and that they're actually paying the bill, etc. And that actually prevents the plan to kind of put better benefits back to the member, right? From a health plan perspective, right? So if they know what the cost is to take care and they're missing that revenue, I'll take few benefits. Let's say a plan is exploring, food benefits, transportation benefits for patients and members who are undergoing certain cancer conditions. Then if they're already missing it, then they may not be able to put that money in to, and ultimately for the members to have that benefit. Who, I've seen many members, and in my experience in the health plan side, getting real benefits out of these meal plan, et cetera, transportation especially, right? So that's one example of a missed condition that could actually drive potentially negative outcomes and, negative experience and benefit for members. But also the other side sometimes could be true too in certain areas if if it's too much, like if it's over documented, we talked about RADV, misdocumented, etc. Then the plan is getting more revenue than anticipated for the member. The member, is miscoded, from a health plan, perspective, and the health plan is expecting more revenue. And then, from a member perspective, in the next year, they have to reduce benefits in the next 2, 3 years, and then the member will be looking to switch plans. Ideally, if the member is in the same plan for a number of years, and if it's like a good plan, it makes life job easy as a member, right? But you have to constantly switch, and you have to learn about the new plan and their benefits, and think of a family who's actually taking care of a cancer patient for a number of years. It's difficult. It makes life, difficult for them. So just giving the two sides of the coin from a member perspective and a plan perspective here.
Sure. And yeah, and I mean, from a clinician perspective, there are plenty of examples, but I'll give you one, right? So, say somebody has profound anemia, low hemoglobin, right? And the clinician hasn't documented it. And next thing you know, the patient is being referred to a specialist, like a hematologist, right? And then the plan is like, why is this patient being referred? We don't know, right? And they might even deny it. So that may lead to more back and forth paperwork, and then care gets delayed. So,
Yeah,
so
there you
it's
go. That's a fantastic example. The care gets delayed. That's like they need immediate help,
exactly.
right then and there.
Yeah, yeah. So yeah, it is critical, but we put a lot of different burdens on the physician, right? So coding sometimes gets pushed to the backside, but that's where we need to kind of educate why it's important to do it correctly and to the most what's a specific extent as possible. Right. So while we are talking about this, what key performance indicators or KPIs should forward-looking leaders track if they want to align risk adjustment, documentation, and quality performance?
Yeah. So the key performance indicators or etc. I think there are a number of standard key performance indicators, I would say, and I think I'll add a little bit more color, with all the different stuff going on from a CMS perspective and a regulation perspective, right? The typical key performance indicators, from a health plan perspective, and also I'll speak from a provider perspective, and would love your thoughts around, right? Like from a doctor perspective. So the ultimately, from a risk adjustment side, we talked about creating members members seen by a provider, face to face. It starts with that, right?
Yeah.
What's the provider, what's the members rate at which like they're reaching they're actually seeing the providers. It starts there. It's fundamental. And then after that, what something called as recapture rate, right? So if
Yeah.
the historic conditions are right, as long as it's right, are they recapturing the conditions year over year, right? And that is high the recapture rate, the more accurate the revenue and the risk scores, are going to be. And then in terms of while they could capture, so Dr. Sunil, you may be capturing those conditions right at a point of care or some other means, but is that going to the health plan? Is the health plan submitting
Yeah.
those diagnoses properly to the system at CMS? And then is that actually used across the ecosystem of systems and processes within the health plan to coordinate care for the members? So within that, there are a number of key performance indicators such as accuracy rate of submissions,
Mhm.
how accurate the submission rates are. Are there any leakages between providers and health plans? Back to the example that we talked about, right? And I've encountered many times, like when we send a list of conditions to providers, like, yeah, I see them every time, I code them, right?
Mhm.
But maybe
Yeah.
there's like some leakage going on between the claim processing, between the provider, on the payer. So that's a little bit more on the operational side there, right? For risk adjustment. The risk scores that are coming out of it, is you can control what you can control, right? You can control all these different things, different key performance indicators, and then based on the type of population the health plan actually is covering, the risk score would be the outcome,
Yeah.
of that, because too many people forget risk score is a combination of the member demographic and the chronic conditions together,
Mhm.
right? So
Yeah.
it's just not the chronic conditions alone. It
Right.
depends on the member demographic the health plan has. So typically, like a dual SNP plan or an SNP plan, they have a higher risk score because their chronic conditions are different. So the risk score is often an outcome and not a leading indicator. From a star rating perspective, we can keep talking for a long time, when you think about key performance indicators. So while you have number of 40 plus different measures, within the star rating system, so there could be key performance indicators for each one of them, but at the same time, there could be key performance indicators. We don't talk about this often, on the medication adherence. In adherence side, you have many different pharmacy related measures on adherence and related measures. There could be engagement with members, operational, KPIs related to the pharmacy operations behind, what's the, rate at which the PDEs are accurate. Those are some critical key performance indicators. So to kind of put it in a package, right? So while there are all of these kind of like key indicators that leaders and also the operators within the health plan work on, it is also critical to kind of align that with the provider and health system, what their motives are. There could be some value based contracts that the health plan and the health system has. There could be a lot of common indicators of performance from a different lens. Providers look at a different lens, but as much as possible, really kind of like work together on those ultimately for a member outcome. So these are some low hanging fruits from a star and quality perspective, but at the same time, it's time to think about way bigger than this, right? So it's how do you kind of really manage the population? What's the rate at which you can actually reduce the progress of chronic disease? In the US is like rated like really low in terms of like the burden of chronic disease and cost, how do we, as not only as a health plan or provider, but as a system, how do we kind of reduce that burden? Right. So those are some things that, evolving things that we can think about, using technology, using, right kind of people and right kind of process. But I'm looking forward to, probably it's an whole another podcast episode about those indicators. But that is what I'm optimistic about, to see how we can, go from, the traditional KPIs to some evolving KPIs that we can all kind of really rally the troops to reduce the burden of chronic disease in our country.
Yeah, I mean that's massive. I mean that is foundational, right?
Yeah.
I mean, in terms of the money that gets spent on chronic care, and you even look at life expectancy in the U.S. versus rest of the developed world, and we are
Yeah.
not doing great, right? Considering
Yes.
all the expense that we make. So yeah, I think that's a big one. But I'll tell you from clinic provider perspective, who has been in the sort of value-based care system, the couple things that I always looked at. One was obvious star ratings, right? Like my cohort of patients, what am I doing, right? And we got all these regular updates from the health plans. So are we higher than 4? Are we going higher and things like that? So that's one thing I looked at. And the second thing from a risk perspective, I think one thing that I thought was always a very key, just one number, was the MLR, right? The medical loss ratio. So
Yeah.
if I'm doing a proper job of risk adjustment, meaning documentation, and I'm doing a good job of taking care of the patient, seeing them when they need to be seen, not letting, I mean, if somebody needs to go to the ER, they need to go to the ER, right? But generally speaking, being available, being engaged, so, you are managing it basically cost effectively, right? Not too low MLR, because that also is a bit of a red flag, because then, you are maybe overcoding, right? But in the right range, I thought that was always that is a very critical part of how you kind of judge
Yeah.
how you're performing, right? So,
Yeah. No, it's interesting, Sunil. Like, I've seen some plans be part of also having higher, even the risk score is better. The recapture rates are higher. The MLR sometimes are higher, and it's not really, sometimes even with risk, the really optimal risk score, the MLR really being higher. We've seen that, right?
mm,
Because that's also because the risk adjustment, while it's supposed to kind of accurately kind of predict, like the cost, it's not a perfect system,
no.
right? You could have other factors that are boosting the cost of care, that are some many times like not related to the current model,
Plus, it does
risk
not get
adjustment.
translated till a year or two later, right?
Yeah,
After
that's
even
also that it
after
doesn't get
intervention.
translated a year or two later. So, but directionally, yes, to your
Mhm,
point, right? So that's awesome that you track them, and having a directional kind of like a view of like, okay, ideally it should be in this range,
mhm.
between MLR risk scores and quality. It actually kind of opens up the conversation to kind of dig deeper to say what may be going on beyond risk adjustment and quality.
Exactly. Yep. Yep. All right. So, last question. So, you've helped both payers and providers break through the ceiling of compliance. So, what advice do you have for leaders who want to turn the data burden into actually a quality engine?
Yeah. So it's a tough question. That's why it's the last question. So number one, I think we're talking about compliance. I think given the context of what's happening on the risk adjustment data validation RADV side, right? So from a provider and payer perspective, interoperable a way of working together with the member, whether its solution is that's in the in the workflow of providers, and making sure that your the system is helping the providers to kind of like delivering that care easily, and also supplying the right data, right? Not and being very conservative and thoughtful, right? Because there are lots of AI applications out, there's a lot of hype of AI, especially in the risk adjustment world. Is a really, really a tricky situation, right? So you don't want to, over code And it starts with the reason why risk adjustment exists is more for accuracy, not just for revenue, right?
Exactly.
And
The more
also,
substance, less noise, right?
yeah, and then also for quality. Is this code, if the person, if it's documented, you had a great example of the, anemia in a condition. If that is actually hypercritical, is it fed rightly, correctly from the health plan side, to the provider and vice versa? And is this getting translated to the member or members, caregiver, etc., who are working with them? So often we talk about the interoperability piece between the provider and the payer, but also it's like, is this getting translated right, correctly to the member? And then do they know what actions they need to kind of take, using that data? Some of the work that I've done in the past is it's revolving around that. I'll take another example, right? Home assessments. Medicare Advantage, there's health plans use home assessments as a way of getting to know the member a little bit more beyond just like the codes that they get from claims, etc., but also getting into the member's home. It's very controversial, but at the same time, it could be very powerful if the program is set up correctly to really use that program to drive overall outcomes. Understand the social determinants, needs for those members, deliver meal while you're there. Take a blood test if the member is not able to go to the nearby lab. They can draw the blood test, run right then and there. But you can all do that. But how do you kind of really the key is to get that delivered to the patient's PCP or specialist who's working. Get them delivered to the health plan so that they know what is going on, and also not only within the health plan, but from the health plan data streams, it needs to be appropriately updated to whether the care management systems they have, whether the utilization management systems they have, call centers they have. There may be quality teams who are actually ready to kind of reach out to those members anytime to close those gaps. So those needs to be updated in a very cohesive and an accurate manner. So I'm hopeful that the work that we all will be doing as an ecosystem will take us to a better system.
Yeah, absolutely. And I'll tell you from my experience, I don't know that I've ever seen anything necessarily come through to me from an in-home assessment, right? That
Yeah,
all this, so for it to truly be something that impacts patient care, that communication needs to happen. Otherwise, it is what it appears is a way to generate more revenue, right?
yeah,
So,
yeah.
yeah,
And wouldn't that be awesome if home assessment data is also the summary of that data goes into the provider's kind of
EMR.
workflow, and then the provider takes an action. Oh, by the way, oh, it's great to know this member has these food problems,
Exactly.
and I would, I'll keep that in mind, during the next visit and see what I can do.
Wonderful. Thank you. That's a wrap on this episode of Care Decoded, and huge thanks to you, Subbu, for breaking it down how we can turn risk adjustment into a quality engine. And
Thank you, Sunil. I enjoyed it.
thank you. So, what listeners, if you found value in today's conversation, please follow the show, share with a colleague, and let's keep decoding care together.